Hello, good evening. Hi, it's Dr.Verdiales from the Georgia office. I know I'm a few minutes late. It's a very rainy day today at all right. Sorry. I'm like, what happened? Okay. Anyway, so hello. Hi, everybody. So today I want to talk about the workup. Okay. I don't know what happened. I clicked something and it kind of disappeared, but we're here. We're here together. So anyway, I always like to talk about a subject and then go into your questions. So I want to briefly discuss the testing. That's something that I've been getting questions about. What can be done, what can be tested prior to your consult with one of the physicians. So like I've said in a few other lives, it takes 5 things to make a baby, okay? Healthy sperm, healthy egg, healthy uterus, healthy tubes, and a healthy vessel. Okay, so those are the minimum things that you really want to check prior, if you have the capability prior to your visit. So semen analysis, it's extremely economical with CNY, but if you get that ahead of time, that saves you time. Ovarian reserve. How do we check the ovarian reserve? We do the famous AMH, or anti-Mullerian hormone, and that gives us an idea of what to expect in terms of recruitment. Okay, the higher the AMH, the more eggs that are expected to be recruited. The other parameters are day 3 labs, so FSH and LH on day 3. That gives us a lot of information on how your ovaries are working. Estrogen and progesterone on day 3 as well. Because what happens is on low reserve patients, sometimes we see a discrepancy in those numbers on that day 3. So between that and the low AMH, it lets us know that it's really, really low reserve, versus having a low AMH, but then normal day 3 labs. That's actually a better scenario. FSH, LH, estradiol, and progesterone varies a lot through the cycle. That's why all the studies were on day 3, and that was the one that got, kind of standard deviated and all the statistics around it. Okay. Then we want to make sure your thyroid, your pituitary are working well. And why? Because those can present, if there's any problem with ovulation issues. Okay, so we check the prolactin for the pituitary and the thyroid stimulating hormone for the thyroid. I personally like to check for possible diabetes or insulin resistance scenario with something called a hemoglobin A1C. And then checking the overall health. So, your sexually transmitted diseases, your blood count, your electrolytes, checking for any issues with liver, kidneys, because, especially the liver, we're going to hammer you with medication that's really rough on the liver. We want to make sure that there's nothing that is already stressing out that liver. So again, the vessel, the woman that's going to carry, we want to make sure that she's in optimal health. The tubes get checked with a hysterosalpingogram. I actually had this question, earlier, and I noticed that, there was one patient that really was hammering, Dr. Kiltz and another of the doctors about whether the hysterosalpingogram was necessary versus the saline ultrasound. So let me explain that. I think it's important. The hysterosalpingogram is the dye test. okay? And that is the gold standard to check on the tubes. However, with the new sonogram machines, the saline ultrasound, a lot of times you can see tubal patency, and there is a test called the IsoView that is with kind of air bubble, so you can see the air bubble go through, and you don't necessarily need the hysterosalpingogram. Now, if during the saline sonogram, you can't really distinguish very well the tubes, and a lot of times it's very, very clear. I did one today, and it was clear that her right tube was open and the left was blocked. I mean, you can actually see the fluid exiting the uterus and then swirling around the ovary. So you can really see, and then you could see that the other side, it was going nowhere. But if you can't see it, then yes, you will need a hysterosalpingogram to check on the tubes. The saline ultrasound is really to check on the cavity itself, make sure there's no submucosal fibroids or polyps that could be causing issues. We have found septums. Septum is like a little wall inside the uterus. We have found bicornuate uterus, heart-shaped uteruses, and different variations of that. And of course, with the saline ultrasound, you're going to see the outside of the uterus as well. So if there's any fibroids, any ovarian cysts, that could be an issue going into possible stimulation, whether it's oral or injections. Okay. So that's kind of the whole thing in terms of kind of the minimum. Then you have layers or more detailed studies, going into karyotype and genetic screening. It's cheaper to screen the parents than it is to screen the embryos. That's another huge question that I get about testing embryos. Now, it's very important for you to know that I get a lot of older patients or low ovarian reserve patients that want to do PGT testing because they're older, but then a lot of times, even if that's the plan, if the embryo don't get to day 5 or beyond, then you can't test them. So just keep your, a very open mind about it. And there are risks of the biopsy itself to the embryo. So, it's easier to test the parents than to test the embryo. It's a lot cheaper to test the parents than to test the embryo. So things to ponder. All right, I see that it's going all over the place. So let's see what you got for me today. Okay, how soon can I take serapeptase after having surgery? Immediately. I love doing enzyme therapy for endometriosis, for tubal issues, and for history of adhesions. I love serapeptase. I combine it with protease. Not everybody tolerates protease. I personally can't. It just messes my stomach too bad. But you can combine it with the bromelain and papain, for example. That will decrease inflammation and try to dissolve some of the scar tissue. There's plenty of testimonials online of people that just with enzyme therapy haven't blocked their tubes and end up getting pregnant naturally. And I think that's the reason that the pineapples are kind of, the symbol of fertility. A patient actually asked me 2 days ago, why the pineapple? And I'm thinking, well, maybe it's the bromelain. It's the enzyme that is associated with decreased inflammation. So, okay. Yes. Oh, that's so sweet, Tiffany. Yes, I love what I do. I mean, even if I was a multimillionaire, I would never stop doing what I do. It's so rewarding to work with you guys. I've been doing this for 20 years, and I'm planning to do it for another 40. So Tiffany, anytime, if you want to talk to me on a kind of a more detailed private setting, just send me a message through Messenger. Maribel Verdiales, MD, and I'll make sure you get on my schedule. I'll give the message to one of the ladies. Do you do an SSG test and ultrasound as part of the monitoring, you do it ahead of time. There are certain occasions where I have agreed to do a saline ultrasound early on a stimulation patient that had, let's say, polyp removes, and she wants to make sure to see if maybe a fresh is possible, but in general, it's done. I call it the discovery phase. So meaning at least a month before you're actually going to start your treatment, you do all the testing. And then during the treatment itself, you really don't want to be, messing around with the ovaries and the tubes and the uterus. I have abnormal morphology and fell just below 4%. We are doing egg retrieval and implantation the next 2 weeks. What are the chances of being successful? Luckily for all of you, ICSI, it's included in the in all of the basic packages for CNY. And what is ICSI? Traditional IVF is you get the egg and put in the petri dish, and you just throw the sperm and let nature do its thing. ICSI, you have an embryologist actually pick the most healthy looking sperm and injecting it into the egg. So you need a lot less normal eggs to have a successful fertilization. I haven't mentioned it in a while, but I have been doing a pilot study on testicular PRP. So I've been working with some of the male patients, and we've had really good results so far. So if you're interested to help me with data and I help you with your issue, just message me through Messenger. I am in the Georgia office. I'm actually in Monroe, Georgia. That's 45 minutes east of Atlanta. Okay. What is a normal AMH? All right, that's a good question. Anti-Mullerian hormone. So normal is always relative, right? It is considered in general, rule of thumb, that anything under 1 is considered low. However, there are ranges depending on your age group. Because, for example, if you are 30 and your AMH is 1.1, that is low. Because an AMH for a 30, 32-year-old should be like 2 or 3. Okay, so, and the other thing is we get this value and we don't know where you're coming from either. So it's very important to create a pattern to see where you're heading. 2.9 in general is considered normal, Vanessa. Have you heard a correlation between using low-dose aspirin and subchorionic hemorrhage? Anytime you use anticoagulation in pregnancy is very delicate. Why do I say that? Because it is best used on somebody that we have a suspicion of a coagulation disorder. So sometimes, actually, I got asked this question today. Somebody with a subchorionic hemorrhage and it's on Lovenox, what do we do? Do we stop the Lovenox? And then could we make that worse? Could we make that better? In her particular case, I chose to keep her on the Lovenox and just bring her back and observe her because of her clinical scenario. So it's and aspirin, it's a very potent anticoagulant because it cannot be reversed. It adheres to the platelets for 7 days, while Lovenox or heparin, you stop it, and heparin is like within hours. Lovenox is 24 hours and it's out of your system. So low dose aspirin the entire pregnancy, it's probably not a good idea. So Dia is asking if she has a order for December and she can still use it. In general, yes. The orders that we put on your portal, we usually do not date them. So you should be fine. I heard that the fallopian tube test flushes out the tubes, and yes, anecdotally, all it's mechanical, right? So either a saline or a hysterosalpingogram, and then people get pregnant immediately just by flushing the tubes. I actually flush the tubes with PRP, and I have great results with that, especially after a tubal reversal. I will use PRP a week or two after to make sure that those tubes heal, or heal open. If I had a tubal ligation, why would they want me to have a saline ultrasound? Because the saline ultrasound is the gold standard to evaluate the cavity of the uterus. Okay, so we want to make sure that the cavity is okay. Also, while you're doing the saline ultrasound, because you are injecting saline, you're verifying that if the remnant of your tube is filling up, it might be a good idea to remove it altogether. So that is the reason that we like to have a thorough evaluation. We're trying, I know that you guys, it's a tough journey, it's a long journey, but cutting corners, it's not going to benefit you at the end, because then what happens, and I see it all the time, you cut corners, then you go through IVF, then it fails, and then you have to go back to figure out what could be fixed. Hey, Yatsaira, no te veo hace tiempo. All right. How often should you do karyotype testing? Once in your life. Your karyotype will never change. That is a good thing, right? So even though genetic testing might be seen to you guys as, an unnecessary expense, I know that the company we use in Georgia is Invitae, and it's $300 to do something like 250 gene mutations. And if you add your husband, it's just another extra $100. So between both of you, it's like $400. It seems like a lot, but your DNA is never going to change. So that one test is the same forever and ever. Same thing with your karyotype. So if you had done your karyotype 10 years ago and you have the results, it's as good as new. Can the SSG and saline ultrasound be done at the same time? Yes, as a matter of fact, that is what is done in most of the CNY locations. So when I go to Syracuse, it's like they're both done at the same time. The workup is not included in the IVF package, okay? So that all the testing and the sonograms and the dye tests and the semen analysis, that's separate from the IVF package. In general, I have a question here about testing. In general, we like to have blood work within the year. And sometimes we're a little bit more lenient about the hysterosalpingogram. I know that that could be the test from hell. But if it's like more than 2-3 years old, then I would probably encourage you to repeat it. Okay. Does TSH level jump drastically when pregnant with twins after IVF? Yes. There is something called transient hypothyroidism of pregnancy, and it is an increased demand on your thyroid, and you're going to see an increase on those TSH levels. It is transient. Sometimes we address it, but it might, most of the times, if you were just pregnant out on the street, it would be just observed, and usually it levels out by the second trimester. It's an AMH of 1.8 and FSH of 10.9 at 34, low ovarian reserve. No, it's fine. If that's your day 3, I would repeat that. It's a little high, FSH of almost 11 on a day 3. So I would repeat that because your AMH it's okay, to make sure that I like to see it under 10 ideally, because usually after 15, the response to the medication is poor. If they took 16 eggs, that it mean that my AMH is high. That means that your AMH is probably good. 16 eggs is a good number for egg retrieval. I had 2 failed transfers, 1 fresh chemical and 1 frozen. Should I do an ERA? Yes. You are the person. That is the scenario where I would recommend doing an endometrial receptivity assay. So what is that? That is actually a mock transfer. And that's something that sometimes patients don't quite get. You have to do the monitoring, and you have to do it exactly how you're going to do it when you're going to transfer. So if you're going to do a natural transfer or a letrozole transfer or a medicated transfer, you're going to do an ERA the same way, and you're going to do the monitoring like you're going to transfer, take the medication like you're going to transfer, and then on the 5th day of progesterone, you do a biopsy. At that time, if you've had those issues, I would send 2 biopsies. I would send one to Igenomics for the ERA, and I would send one to the regular lab to check for endometritis. I've been seeing a lot of chronic endometritis and inflammation lately, so I've been getting antibiotic happy these days. How long the trigger shots stay in your system? Just a few days. Is bruising with Lovenox common? Yes. It is an anticoagulant, and so it's going to be more concentrated on the area it got injected. So then, yes, you're going to have all these bruises in your stomach. What can be done to improve that? Not a lot. You can ice it. Yes. So normally, I have somebody here that spoke to me earlier today. Normally, I will put in your orders right away. Unfortunately, there was an update in the system, so the computer system is not letting me send prescriptions under my username. So as that is getting worked up, I need to, the nurses have to send the orders, so they will be sent tomorrow. Okay. Why does CNY want me to do a saline ultrasound and a hysterosalpingogram when we have a male factor infertility only? Because it takes 2 to make a baby, and we want to make sure that you are 100% okay. You'll be surprised the amount of times that we find things on both partners, and it's a compound issue. Okay. All right. What is the initial cost? What is the cost of an initial workup without the genetic testing? Because that's, like I said, it's $400 for the couple. It's about $500, I think, $600 for the workup. It's $50 for the semen analysis, $165 for the saline ultrasound. I'm not sure how much the hysterosalpingogram is, and then the blood work is roughly like $350. I am not sure what to do. You had 2 failed FETs. What else can we do to increase success? Once you have 2 failed embryo transfers, I would recommend that you kind of stop and see. Check for endometritis, so the biopsy, potentially do an ERA, check for coagulation disorders, autoimmune disorders, check for, and I would probably even put you on the antibiotics and treat you empirically for possible endometritis. Potentially do uterine priming. I do that with certain supplements. You can be on the molecular fertility prenatal, the ovarian bloom. I like a company called Standard Process. It has some uterine supplements that I put people on, food-based vitamin E, CBD oil, potentially laparoscopy, hysteroscopy, and spice up the program. Did you do 2 medicated cycles? Then do a letrozole cycle. What is that? So instead of having estrogen and progesterone, it's actually an ovulatory cycle. We give you medication to ovulate trigger, and then do progesterone supplementation. And the benefit to that is that you're going to be making your own progesterone because it was an ovulatory cycle. So a lot of women do better on that. So, kind of spice it up, maybe add different add-ons, looking at your immune protocol. Are you doing Lovenox? Are you doing prednisone? Are you doing intralipids? Are you doing Plaquenil? What have you done and what have you not done? There's PRP washes, Neupogen washes, ACG washes. So kind of spice up the program. Can I have orders for testing and workup before my consultation? No. In general, no. It's something that maybe your OBGYN might be willing to help you with. But legally, we can't write orders for patients that are not our patients. Okay. All right. How often should you do an ERA? Just once. I do have a patient that she just had her second ERA, but the reason is that she's changing her protocol. So she did an ERA on a medicated cycle, and she did an ERA on a letrozole cycle. But once you have it, that's it. You don't have to repeat it unless you check it out. Congratulations, Karine. God bless. Okay. AMH 2.27, almost 39. I've had an ectopic pregnancy, left tube remove. Everything else looks good. Can the other two cause a problem? Yes. If your saline and your hysterosalpingogram is normal after the ectopic, then it should be fine. So you could even try to do hyperovulation, so do injectables to make sure you ovulate from both sides, and do IUI if the semen analysis is normal. That is an alternative with one tube. So Mr. Frederick, send me a message through Messenger if you're interested in the testicular PRP. So it's my name through my Facebook page, and send me all of your information, so date of birth, phone number, and somebody will reach out to you tomorrow. What is a good AMH for somebody over 40? Over 40, things get really sticky. Ideally, hey, let's have AMH of 5 at 42. I mean, that would be amazing. But if we can work with an AMH above 1, it's really, really good. And I've seen AMHs high on 40-something-year-olds, but I've also seen AMHs very low on a 37-year-old. So it gets kind of messy once we get closer to 40 and beyond. On a baseline ultrasound, what does it mean if fluid is found in the lining but blood draw pregnancy test is negative? Is it safe to continue? Yes, I mean, it is your baseline, meaning you are on your 3rd day of your period, so there's still going to be fluid in the cavity. You could get some mucinex or some Claritin to try to dry it up a little bit. If that's it, if it's a little bit, I usually just leave it alone. It'll clear by the time you're ready to do retrieval. How much is the gender testing? I know in general, PGT testing is about $4,000. So you have to do the testing to get the gender. I was diagnosed with endometriosis today. Is there anything I can do to help prep myself for IVF? Absolutely. Get off grains. The diet is the easiest thing. It's the easiest intervention that you could do. So keto, get off the grains, wheat, corn, soy, oats, sodas, processed foods, clean up your diet. Serapeptase for you would be fantastic. Enzyme therapy, one of our other friends was talking about, for endometriosis would be great, especially if you just got laparoscopy done. PRP, and enzymes. I usually support the spleen for endometriosis in the alternative world. Okay, there are theories that the natural killer cells that are produced mostly on the spleen are the ones responsible to clear the endometriosis. So if you support the spleen indirectly, you clear whatever's left. And I had this question today by one of my surgical patients. You really want to do a short priming because the 6 months after having laparoscopy and clean up the pelvis is the best time to do any type of fertility treatment for endometriosis. Okay. All right, all right, all right. I had put a response on STEAM before retrieval, 2 follicles, cancel and doing time intercourse instead. FSH 12. So I would do some, even though your AMH was 1.4, this is very interesting. This is what I'm saying about not taking those numbers like it's law. We don't know, Diana, where you started, right? So it might be that your normal's 5, so 1 is low for you, because if that's the scenario, you're responding like a low responder. So then I would treat you as a low responder, meaning I would do human growth hormone, LDN diet, supplements, BRP 1 to 3 months before trying to do another retrieval. And sometimes I will get you guys on letrozole, oral ovulation medication, to kind of get you to start cycling a little bit more normal before you jump into a cycle. I am on cycle day 14, lining 6.4, estradiol level is 4,000. That's pretty juicy. Was going to do PRP tomorrow. Should we cancel this cycle instead? If you're doing an FET transfer, no. There's no need to cancel. If you're doing a retrieval and the estradiol level is 4,000, then you're not a candidate for a fresh transfer. Okay, all right. I know that you have tons and tons and tons of questions. So time's up for tonight. If you want to reach out to me, if I could not get to your question tonight, just feel free to text me through Messenger. I know that sometimes, it takes me a day or two, but I do look at all of those message that you send me, and I try to be very responsive. I'm here to help you. So may you all be blessed. I will be with the Spanish crowd on Sunday at 8 and with you guys next Tuesday at night. Have a great rest of your week. Bye-bye.